Gapio. He's president of Gapio and the group medical head for Apollo Hospitals Group in India. He is basically a pediatric gastroenterologist and hepatologist. So I'll request Dr. Sibyl to please start the session. Thank you.
Thank you very much, Sushil. A very warm welcome to colleagues. For those of us who are joining for the first time, Gapio aims to bring 1.4 million physicians of Indian origin across the globe on one platform. We now have members from 54 countries. Gapio has collaborations with many national, international societies, and we're really happy that this collaboration with the Association of Robotic and Innovation Surgeons, and we are collaborating. And I'd like to welcome you to this session on new robotic devices on the block. What is the early experience? I think in the next 5 years or so, we are really going to see a huge change in terms of use of robotics with increasing access. And I guess perhaps it's like what it was in the late 80s and early 90s with laparoscopic surgery. I think one of the biggest challenges has been the cost, the high cost initially, and then the consumables, and that is only going to come down. So I think it's really important that we look at what is available out there. And I think we also need to be cognizant of the fact that India is making progress with Make in India. So really happy about that. So let me introduce my colleague and dear friend, Arun. Dr. Arun Prasad is the moderator for today's session. He's a senior consultant in GI bariatric surgery at Apollo Hospitals, New Delhi. He has the experience of performing more than 10,000 laparoscopic surgeries, 1,500 bariatric surgeries, and 500 robotic surgeries. He's former president of the Obesity Surgery Society of India and president of the International MGB OAGB Club for Bariatric Surgery. He's the editor of the Journal of Minimal Access Surgery, the World Journal of Gastroenterology, a reviewer for several other journals, and currently the vice president of ARIS. He has 55 publications. So over to you, Arun.
Thank you, Anupam, for those kind words. And thank you very much for making me a robotic surgeon when you got the robot for all the Apollo hospitals in 2012. So it's been a great journey over the last 10 years. Now, one of the problems which we have faced in the last 10 years as robotic surgeons, not just at Apollo, but in India and across the world, has been the monopoly of one particular company, which has dictated things more in terms of economics and also somewhat in terms of feedbacks. So, many times surgeons have given feedbacks and wanted certain improvements in the robotics, and that has not materialized. So of late, we've had a few robots which have come, and some of them have got introduced in India. And these robots are very promising. And we are all hoping that this kind of a healthy competition that all the new robots will generate would not just lead to a reduction in the cost and maintenance, but also it will lead to an upgradation of the technology, because the current robot is just the very beginning of the revolution which we are seeing, where computers and technology is going to be used in the future by surgeons for the benefit of the patients. So without wasting much more time, I will request my dear friend and a senior consultant, clinical director, colorectal and robotic surgeon, Dr. Selva Sekar, who is at the Trust Christie NHS Foundation, Manchester. He's also served as honorary senior lecturer at Manchester University, Edge Hill University. He has published numerous publications and has received awards like the Chatterjee Oration and Professor B.K. Rao Oration for robotic colorectal surgery. We are also together in running a series of robotic webinars for the Royal College of Surgeons, where Dr. Selva Sekar has been taking a great lead. So now I'll hand over to Dr. Selva Sekar to proceed further with this meeting, where we are looking forward to seeing some first-hand experience with the Hugo robot, with the CMR robot, and also the new kid on the block, which is the SSI robot, which is going to be a made in India robot from Gurgaon. So Dr. Selvasekar, over to you.
Thank you very much, Dr. Arun Prasad, for kind introduction. And I'm truly honored and privileged to be a part of this group. For some reason, which we'll probably explore later during discussion, the robotics have taken up a big way in India. And all the newer robots, the clinical trials have been done in India, and with Indian surgeons taking a huge role in ensuring that it is all used in a safe way for patient care, which is it's very interesting how things are moved on from the west to the east, and the Hugo, the CMR, and also the Indian robot, which we are going to talk about today. It is really an innovative way by which the surgical fraternity from India has taken this technology to benefit patient care. So I'm really honored to be a part of this presentation today. So without much ado, I will introduce the first presenter, Dr. Palniappan, who is a bariatric and a metabolic surgeon based at Apollo Hospital in Chennai. We met a couple of months back when the team from Edge Hill University went to Apollo Chennai to see their the simulation and the educational facility. He has led bariatric surgery, and he's been the first to do the revision bariatric surgery. And he has got a lot of first in his portfolio. As I can see, he has done the SILS, gastric bypass surgery, cardiomyotomy, gastrojejunostomy. I don't think he has left anything unturned so far as I can see. And he has also been a part of the Dundee multi-tool hand-assisted laparoscopic surgery. And he seems to be leading the way in using the Hugo robot. So let us hear from them. Over to you, Dr. Palniappan. Thank you very much.
Thank you so much, Dr. Chella. Thank you for a kind introduction. So we all know that robotics has come here to stay. And when you talk about robotics, we always knew that it is only Da Vinci until maybe 3 years ago in 2018-19, when we started having a CMR, which is hit the market in a very a broad way. Then now we have two more which has jumped into the market with Hugo Ross and recently SSI. So I am fortunate to have Apollo Hospitals to help us with having a Hugo Ross here. Maybe started in last September, but I did my first surgery in July when general surgery and bariatrics have approved maybe in June. And so without further delay, let me go into my initial experience of Hugo Ross robotics. When it comes to Hugo Ross, I would like to have a disclaimer of the contents. Some of them are maybe in clinical trial, maybe strictly only for educational purposes. And data-wise, some data are retrospective data and observational data, so it is not for any reference as such. And sponsors, I don't have any commercial interest, as well as no conflict of interest from my side. Going into robotics, we all know that robotics has its own pros and cons. When it comes to pros, we all know that it's been very beneficial to both patients and surgeons in case of more precise surgery, less pain and fewer complications, and reduced hospital stay and shorter recovery time. Of course, not in all cases, in select patients. Whereas in come to surgeon, definitely it helps in a big way, significantly enhances the visual field, and dexterity is so far superior than minimal access surgery. And of course, better access to areas of concern, especially in the pelvis and the hiatus, and lesser pain and lesser issues about the back and neck of a surgeon. So having a longevity of surgery. However, there are cons which comes with it as well, like cost of surgery, the unlearning the mass principle, and then the initial cost of setting up, and all those things are all pretty much in a difficult state. And this is where, as Dr. Arun Prasad said, new companies coming in is very important for us to make sure that we have a better, surgical robots available for us to, have a more commercially viable projects. So this is a Hugo Robo. This is the console, which has a call stores unit and have a Valley Lab and staplers as well. But as of now, it is not introduced into the country. This is a arm card. There are 4 arm cards available. In this arm card has multiple function, 8 junctions and 7 range of movements. So we'll have a very fluid movement around to help in proper economics of port placement. And this has a lot of advantages of having tilts and angles. So beautifully about 360-degree can be moved around with state-of-the-art instruments and equipments can really do a wonderful job. The surgeon's console, a little bit of a difference in the joystick, but the biggest difference is the open console with the foot pedals similar to what we have in Da Vinci. And being an open console, the operating environment is not compromised. You still know about the whole process of what is happening around, and with very good instruments stated to come. As of now, we are only 9 instruments. With up to 18 instruments going to come, it will be very much better than few of the steps in bariatric, in Da Vinci. And of course, this is the typical advantage of having an open console where you can have an access with the patient card and the surgeon as well. Another big advantage what it has, it can be converted to a laparoscopic pretty easily, just undock, and it can be used as a laparoscopic scope, and laparoscopic instruments can be used. So converting between a laparoscope and a robotic is much more easier with this because of fluid and easily movable arms. And of course, recording, and then you have your own editing all through a special touch screen, touch surgery concept also helps you to store your data, read analytic, everything is possible as well. So as a whole, it has a lot of advantages using Hugo Ross. So with that in mind, we thought we will put across and see how well we perform in our initial experience with a good experience of robotics with Da Vinci for almost 12 years now. So we thought we will put the exercise to understand the difference between these two. When coming to the console, it's an open console which gives a 3D vision as well as without compromising the situational awareness, as I explained. And an easy grip controller allows to control the instruments in a variety of scales and provide a touchscreen settings adjustments in the control pad, which completely controls the whole laparoscopic, whole robotic arms to the data. Everything can be controlled from one setting, and then ergonomically adjustable setting as well. When it comes to system towers, it's a very intelligent system tower which has advanced 3D camera, as I told you, and then multi-use with a console integrated both for manual as well as integrated control for laparoscopy, and then high definition interactive monitor, and includes stapler as well as vessel sealer, which these two are not ready yet. And of course, a digital surgery is again going to be very useful. When you come to the arm cart, it has plenty of advantages. For access, adjustable height can easily manage individually at different levels to help us to set up the cart at different levels at different parts. For example, if you have a steep reverse block, the height can be different for the one arm and height can be lower than the other arm. So it's much easier. And then again, for mobility, easily movable within the OR and into another OTs, and very easy to play with. So that is a huge advantage what we have with it. And of course, other things like tilt and angles of movements, all those things are also much more useful in trying to help the arm to perform better. There are 4 different parts which you need to understand in the arm. One is the arm plane. So arm plane is a big advantage when it comes to Hugo Ross, because here we can have both forward as well as reverse docking possible. So that's a big difference between Hugo Ross and Da Vinci. When talk about forward, means you can have the instrument directly like a laparoscopy operating as well, or the Da Vinci type of a reverse docking possible as well. So the plane can be adjusted depending by using the knob, and whether head first or head hand side or the leg hand side, you fix the plane accordingly. The instrument will do a forward docking or a reverse docking, and the instrument can use accordingly. And again, as I told you, arm height is one which can be brought from 40 to 110 centimeters. Huge difference in the way we can develop measure the height, differentiate the height. Then the tilt. Again, sometimes you need a very higher arm, but the tilt can be done from 0 to 45 degree on both sides up to -45. So that can tilt the arm pretty steep down, facing down, or pretty steep facing up as well, if you want to operate at any given heights. And of course, the arm angle is also very important, where you can twist the angle between all the 360 degree to fix the cart any which way we wanted. So it has 8 different range of movements possible in the arm itself that gives a 360 degree view or 360 degree access to the the abdomen. So when it comes to our bariatric surgery, we had made a new type of a docking system, because docking concept was not taught by the company. So we had to design our own docking based on 3 basic interesting concepts. One is the arm height. As I told you, 70 centimeter is the ideal arm height to be used, because 30 and 30 centimeter below and above is possible to move around the arm when you have at 70 centimeters. So we'll adjust the table height to extent of about such a way that top of the patient is at 70 centimeters. Then right anterior elbow as 10 to 20 centimeter, degrees steep, anterior elbow positioning of the patient. And then we try to do a forward docking wherever possible. So we did a forward docking with all the 3 arms. What we used, instead of 4 arms, we did 3 arms. And as the picture depicts, the patient in a leg split position, the telescopic arm comes from the left side of the leg of the patient. And the beauty about the Higoras is we can fix up the angles, the tilt of -15 and dock of 150 degree. So when you do those docking and a height of 70, you just don't have to fix the arm as per you want. You just go on, elevate the table height, fix the tilt, fix the dock. The patient table is perfectly close to the port where you wanted to have. So these ways, all memorized docking positions can be fixed. For example, the left non-dominant hand with a docking angle of 300 and a tilt of -45, and docking hand of 60, and so likewise for a dominant hand. So for this, all 3 can be easily locked, so that the standardization of procedure is pretty easy. And then we used a 8 to 12 mm for the dominant hand, where we used a 12 mm prakar for both stapling if necessary, as well as any other 10 mm instruments or 8 mm instrument. And 11 mm scope we never disturbed. And the non-dominant hand is 8 mm, because it's going to be 8 mm instrument for retraction and sometimes dissection alone. Then also always in a non-Da Vinci robo, we need a 8 to 12 mm assist port. If you need a 4th arm, the 4th arm can be also fixed with a tilt of 15 degree and a dock of 260 degrees. So 4 arms can be used. We use only 3 arms, and assistant uses 10 to 12 mm port here, assist port, which again is very useful for stapler, for suction, as well as any traction techniques. And the monitor is on the head end of the patient, on the right side of the left shoulder, and we have the right side of the leg side of the patient facing the patient. We have the console, so that being an open console, it is very easy for the surgeon to have a continuity of the surgery as in a normal laparoscopic way, which is a huge benefit, where we don't have to come out of a procedure as in a Da Vinci and then change the situation around. So this is a typical procedure. We did laparoscopically liver retraction and then use the console, and you see the procedures can be as normal as in laparoscopy. So since we don't have a sonization, while using the sonization, you have the assistant who's doing the sonization from the assist port, whereas I'm holding the stomach to create a retrogastric window below the crow's feet. So this is typically easily pretty possible. And then once that is done, we tend to use the stapler again, since we don't have a stapler as of now, but soon going to come. So you have to use a iDrive Medtronic stapler, what we used here, and pretty much is very easy without arm hitting each other. And again, as I tell you, with very interesting ergonomics, and of course, with the previous experience of Da Vinci, we didn't have any issues in docking and undocking. We could complete the procedure within 2 hours even in our first case of OAGB, no, Hugo Ross OAGB, which is I think the first in Asia Pacific. We did the Hugo Ross. Pretty much staplers and angles doesn't hit each other. All these steps are as precise as in laparoscopy, with an added advantage of more sturdiness. And of course, the help comes much more if it's a true robotic and in suturing than any other ways. You can see the gastric window in the hiatus and that last stapler to complete the pouch creation. Maybe we have one more staplers, still a little bit left, and that's a spleen. This particular patient had a spleen which is the stomach is which stuck to the spleen, and that completes the the gastric pouch creation. And you can see there's not much of a bleeding as well. As being a first case, we're able to manage things well. So then we take around 200 centimeters from the DJ flexure, the bowel. So that's the DJ flexure. We measure
Sorry,
about
Raj.
some 200 centimeters from the DJ flexure.
The video is not coming through. Would you be able
Oh,
to?
but I'm able to see it here. It's still not coming through?
Can you stop sharing and now it's visible.
Now it's thank you.
Yeah, sorry. Yeah. So once the 200 centimeter of proximal bowel is taken from IC junction, I mean from the DJ flexure, then we do a stage suture, and see here we do a laparoscopy because we want to see how comfortable it is to do convert from a robotic to laparoscopy. The advantage is within a minute of within 1 minute, we just undocked and did the bowel walking laparoscopically, and within a couple of minutes we redocked again and continued with robotic, which are much delay at all.
Sorry again,
So,
it's gone off. Would you stop and then restart the screen share, please?
I think, Dr. Raj, whenever you are forwarding the video, it stops getting displayed to the.
I'm not forwarding the video at all. I'm not forwarding the video at all. Maybe stop and start again.
Yeah, that would be better. Stop sharing and start sharing again. Thank you.
It was working well, but it seems to have gone off. Thank you. So if there are questions or comments, please put that on the chat. I can see there's one question already, but please, delegates, put those comments in the chat. Thank you.
So are you able to see now?
Yes, thank you.
Able to see now?
Yes,
Okay. So able to see the video now?
yes.
Yeah. So once the stage suture is done laparoscopically, again we came back to robotic, which is close to 4 minutes of undocking and redocking of the robo. It's pretty simple with the arms, and then we continue with our GJ. So now once the DJ is finished, then that's the whole benefit of robo comes in, where we do a very interesting the closure of enterotomy, which again, like in Da Vinci, no lag, pretty much impressive, except for 1 or 2 small hiccups here and there. We could do really good job with the suturing in Hugo Ross, as good as what we do with Da Vinci as well. So again, the suturing is pretty easy, and the biggest advantage is normally we have some kind of a clash here and there in a Da Vinci arms. We never had that issue, and see here, completely wide scope, and both the arms of the robo. We never had an issue of arm clashing on each other, or the assistant hitting with the arms. So never had our assistant have a problem with arms. So that way, I strongly feel ergonomically it is much more beneficial for a GA surgery, especially because where we are going to do multi-quadrant surgery, and then once this anastomosis is over, typically like what in any our bypasses, we just do a methylene blue leak test, and there is no leak, and that completes the procedure. So it's pretty much comfortably done. And going to literature, there are plenty of literatures available, maybe 7 or 8 literatures available as of now itself on Hugo Ross, and proud to say 2 of them are from our Apollo unit as well. So the evaluation of Hugo Ross and a major urological surgery, as well as the initial experience with the Hugo Ross hernia has come from our hospital. And again, gynecological institutes and other urological institutes also have done about 12 installations in the world. And with, close to around 1,000 surgeries have happened so far in Hugo Ross, I was told. And all the robots are equally performing good in trying to do the task as good as Da Vinci. And in some cases, especially in GI, it has a much more economical advantage over a Da Vinci. Maybe with staplers and sealers, vessel sealers coming by end of the year, it is going to be a big challenge, and that's challenge what we surgeons will enjoy when companies try to bring better equipments. So with our series of 2 cases in the last, we did a study with cases that we did in bariatrics from Jan to July. We did 2 cases from Hugo Ross with the operating time of 131 minutes, consult time of 104 minutes, visual analog score of 6, blood loss of less than 10 ml, length of stay of 2. It is equally comparable with Da Vinci, except for a little less operating time, and that's accountable because with only 2 cases of exposure. When it comes to laparoscopy, again, the huge difference is the operating time. It's 44 minutes in laparoscopy against 120 and 130 in the robotics. Pain score is not much because in Hugo Ross, we still have a stapler assist port, whereas in our last cases of Da Vinci, we do a pure robotic, all staplers, everything robotic. So the pain score is still less in purely robotic than laparoscopy, whereas Hugo Ross still has some way to go. Blood loss is similar, length of stay is similar, no complications. I think it's a very, very feasible one with as good as Da Vinci. Few benefits over Da Vinci in some places. Positives: fluid movement with 8 joints to suit any target axis is a big advantage of the arm cut. Laser height, tilt, angle configuration can be standardized, which will make life of a surgeon easier because when the surgeon comes in, already everything can be docked. He can do like what he does in laparoscopy. Come in straight away, operate the surgery and go away. And forward and reverse docking helps in achieve free arm movements. Sometimes we may have to do, especially in a multi-quadrant where we want to do adducerasis of the pelvis and then go ahead with a forward for a bariatrics. It's very helpful. Same way, multi-quadrant, multi-planar surgery is pretty useful. One arm can be fixed against each other. It's amazing to explore that. Still, since we will not explore it, maybe it's yet to be told how significant that is. Come surgeon's console, open console, which helps them maintain the situational awareness. So constantly in touch with everybody in the OT, like in laparoscopy, where surgeon feels the control of the whole situation, and super happy with that kind of a concept. And then touchpad, which helps in a overall system and status control, so that I control from this surgeon console everything that's happening in the OR, including the instruments, handling from left to right, and the status, all those kind of things. And then, of course, use in robotics and standard minimal access surgery, both can be used. That's an amazing thing. And of course, system tower, open access control is much beneficial. When it comes to the challenges, sorry, when it comes to challenges, okay, sorry, I'll go back. When it comes to challenges, space occupying, because huge space. So when you use 4 arms, a 400 square feet OT itself is not enough. So other cables, spaghetti of cables around, limiting the equipments other than the robotics to use. For example, if you have a harmonic scalpel trolley coming in, a second trolley of the assistant coming in, it's pretty difficult to work around. So that is cumbersome. We need to work on the economics of that part later. And then, of course, very delicate with numerous checks. Sometimes the preparation becomes cumbersome. And of course, paucity of instruments with only 9 instruments. It has a long way to go. When all the instruments are coming, then the real benefit of Hugo Ross comes in. And the beautiful advantage is ClickLine call stores module is going to come in, where you can use a laparoscopic modular scope, instrument, so that we don't have to have any increased instrument cost if you wanted to do a robotic surgery using a laparoscopic instruments. And then maybe a little bit extra cost when it comes to a robotic, maybe especially when you're doing suturing, we can use the needle driver of the robo. Otherwise, call stores, ClickLine instruments can be used both in laparoscopy and robotics. That is a huge advantage of converting from a laparoscopy to robotic. Again, no provision for ultrasonic shear as of now. It is a challenge which needs to be addressed pretty early. And of course, the problem is there is no insufflator with the system, a separate insufflator, a separate trolley for insufflator. So likewise, it increases the dead space in the OT. So it will be good if they can have a complete all-in-one image trolley, which comes with insufflator as well. Conclusion, design-wise, an ideal platform for abdominal surgeries, beneficial to all specialties involving abdominal access. Economic-wise, platform with one of the better economic design to mimic laparoscopy, thus reducing the learning curve as well. Instrument-wise, paucity of instruments, of course, in spite of technology available, it has to, once it matures and comes down, it's going to be much, much beneficial. Outcome-wise, early experience proves to be the system be more efficient and feasible, and outcome is similar like any other robotic device like what we use in Da Vinci. Cost-wise, as of now, doesn't seem to be of economical benefit, but with the new instruments coming in, click line, other things coming in, may be beneficial, which can be the cost of recurrent cost can be reduced easily. Future-wise, new instruments, energy sources definitely will devise the technology to be much more superior and definitely comparable, if not better than Da Vinci. And with the kind of economic advantage it has, maybe it has a much, much better role in abdominal surgeries than Da Vinci, in my opinion, maybe as an initial experience. Thank you so much.
Thank you very much, Dr. Palniappan. That was a fantastic overview of what is happening with the Hugo system. There are some questions, but we'll take the questions at the end. If you can stay online, we can have the discussion with once the other two presentations are over. Thank you very much again. Thank you very much. Next presentation is by Dr. Rajesh Srivastava, who is another bariatric and laparoscopic surgeon. He is based at Gujarat, working at the Sriji Hospital. And he's going to give a presentation on his experience based on the CMR system. We can see his current designation. He's a consultant with HN Reliance Foundation Hospital, Mumbai, director for Sriji Hospital, Gujarat, and he's also an associate professor. He has won multiple awards, which are all nicely alluded in this slide. And his area of presentation is abdominal wall reconstruction, hernia surgery, obesity and metabolic surgery, and advanced laparoscopic surgery. Over to you, Dr. Srivastava. Thank you very much again for giving your presentation today. Thank you.
So, thank you very much, Gapio, Eris, Dr. Arun Prasad sir, and Dr. Anupam sir for this kind opportunity. I bring greeting from Gujarat. Basically, my first exposure was with Da Vinci, as I am attached with HN Reliance Hospital as a hernia surgeon. So we have done till now 5 ETEP leaves to pass, and I started like that only. So basically, my hospital is a rural area of Gujarat, and that it is said that if you wish anything from deep of your heart, the whole system works for you and you get that it. So starting a robotic system in a rural area was little challenge, but by help of so many factors, we could start CMR's robotic surgery in last. Hello.
Yeah, we can hear you. Thank you. We can hear
Hello.
you.
You're audible, Dr. Srivastava.
Hello.
You're audible. Yeah, thank you.
Hello.
Dr.
Hello.
Srivastava, we can hear you.
Hello, am I audible?
Yes.
So video is not running?
Would you screen share again? Come off it and then screen share again. It was, we were able to see it, but it seems to, yeah.
What happened?
Yeah.
So this is the virtual system which is there in our theater. We have till now we have done 12 cases, all 12 cases there of general surgery. We did 4 tap surgeries, 5 gallbladders, and 3 hysterectomies. So this is the picture of our theater. You can see the robotic arms, which Dr. Raj just said. They are again, you can transfer from one theater to other theater. And this is the hand controller. They have given everything in your hand. So this is the Versus system, and you can see this is the console. In the console, you are sitting here peacefully, and you need not to put your head into the console like Da Vinci. These are the mobile bedside units. One is, of course, camera, and rest are hand instruments. And there is an auxiliary screen on which your whole team directly looks the picture. So when we talk about key features, it has modular arms, open surgeon console, small fully registered instruments, transportable. One of the major factor plus point of this Versus system is it is transferable. Better ergonomics, we all know that most of us are robotic surgeon. Advanced dexterity, we all know, and we have a Versus trainer inside it. Suppose you are not operating, but still you can use your robot with virtual hand instruments, and you can practice with the robotic surgery. So this is console, and this is BSU, we call it bedside unit. Now, this is hand controller, and the problem is they have given a problem which I thought, I was skeptical that since the birth of a surgeon in us, we were used to use food plates for cautery. But believe me, in very first case, I was very comfortable with the cautery in the hand. So they have given cautery in the hand, and this is the joystick we call it, from which you control your video system, and this is the clutch. So this is the picture of my theater. Usually we sit and operate, but again a different thing for in Versus system is if you are comfortable with operating in standing position, you can operate in standing position as well. And the ergonomics is good because if you are doing a gallbladder surgery, you are looking towards the head end of the patient. So ergonomics, and you feel you are more in touch with the internal organs. Suppose you are doing hysterectomy, you face towards the foot end of the patient. Now, we all know that difference between laparoscopy and robotic assisted surgery. So I am not going in detail of this. This is very well explained by Dr. Raj about the benefit for the patient and benefit for the surgeon. He has very well elaborated the problems with the robotic surgery as well. So I'm just skipping going to the technical points. So first case, I took a TAPP and see the 7 degree of freedom. I was full of joy when I can see my instruments moving like this. It is simply not possible in laparoscopic surgery. Although as a surgeon, we all know these are flimsy adhesions. They are, you can very well take care of them with robotic surgery. But this 1 minute video only shows the movement of robotic arms which you do. So you can go up, down, 7 degree of freedom we call left, right, up, down, deep, out, and in, out. So the way you want to move your instruments, you can move that, and you can very well see this is of course not beneficial for this flimsy adhesions. But when you are doing deep work into the pelvic cavity, these movements, this 7 degree of movements definitely will help in deep pelvic surgeries, and we know there are surgeons who are doing colectomies with this Versus very well. Now this was my second case, robotic gallbladder. So you are looking to the 2-dimensional picture, that is 2D. But when you operate with the robot, your console shows 3D system, and each and every fibers are so clear. Now you can see the lymph node, which is usually we don't care in open surgery. Of course, we care. I don't deny that. But every fibers you can see in a 3D vision, and you just complete this surgery with hook and a bipolar grasper. So this is the cystic artery which I am taking. Nothing great about it, but the fun of operating on sitting in a on a console and operating is really awesome. So the problem is they don't have staplers, so you have to use Liga clip, and you can take out every fiber of gallbladder or any organ with this. So coming to my second case, the third case, which was hysterectomy, and see, the best part in hysterectomy was, of course, they don't have ultrasonic sealers, they don't have bipolar sealers. So it is a struggle to complete the total laparoscopic hysterectomy, because probably 10 years back we used to do bipolar cautery and then cutting with monopolar scissors. We have very good ultrasonic scissors and bipolar forceps for that. But they don't have right now vessel sealers, but probably in the end of this year, October or November, they are coming up with vessel sealers. See the movement, just see the movement. This is simply not possible in laparoscopic surgery. The moment you just take out the needle from where you want. You can rotate your arms from where you want. You can use your left hand, you can use your right hand. And one statement which I want to clarify, my point of view, it is said that if somebody is not good laparoscopic surgeon, he could be a good robotic surgeon. But to me, I simply deny that. You have to have a good laparoscopic skill, if you have tried or not, but you have to have good laparoscopic skill, and you have to have good movement in your left hand to become a good robotic surgeon. So the saying that if you are not a good laparoscopic surgeon, you can be a good robotic surgeon, at least I simply deny that. So see, from where you want to bring your needle, you can very well bring that, and see every movement is so precise and everything is so clear in 3D vision that doing a general surgery is a fun. So moving your arm, taking stitches, these all are fun, and definitely you can do better with robotic surgery than laparoscopic surgery. Now this is TAPP. So we have done plenty of TAPP. This was our first TAPP in which we took 2 hours. But believe me, the fourth TAPP we just finished in 30 minutes. I am talking 30 minutes after the docking of robot. In CMR system, docking is very easy. It is maximum 15 to 20 minutes job. It's not like other system where you take time. It is very easy, and see, initially you have to learn these movements, but later you are very comfortable with these movements. And of course, every system has some learning curve. You cannot be a master in just 5 or 10 cases, and you must agree with this. So definitely, initially we took 2 hours in unilateral TAPP, but last TAPP it was again. So in this case was also a small direct hernia. We always believe to start with a easy case. And see the clarity, again, it is a 2D picture, but when you sit in console and when you see the 3D picture, it is really awesome and you enjoy doing surgery. So basically, I am a TEP surgeon, and at this point of time, my 80% cases are ETEP. So we inserted a 13 by 15 centimeter mesh, which was a little bit larger for this TAPP. I admit it was a mistake, but anyways, so what we did, we could have sutured the mesh as well, but we thought as it was first case, we just used tackers in this, and we use 3 tackers. Usually, I don't use any fixation device in ETEP, but in this we used tackers at 3-point time. And finally, once your mesh is there, the suturing of this peritoneum flap is fun. It is a fun, and it is so easy because the way you want to move your arm, you can very well move. You can go upside down, downside up, right to left, left to right, whatever. But yes, again, I am telling you, your left hand should be very active. Even in robotic surgery, it is not that robot is doing the surgery. We all know it is you who are doing the surgery. It has learning curve. So my experience with CMR is with these three procedures. We have 12 cases till now and in last 1 month, and we hope with passing time will be more expert and probably will show the better videos in future. So thank you very much. After all, there is something called containment to the surgeon. There was a question also, what is the why not MIS, why robotic? So friends, after all, there is something called containment to the surgeon or satisfaction to the surgeon after surgery. And I can definitely say the satisfaction level in robotic surgery is far, far, far more high. Even after robotic surgery, I can say that I love the food more after robotic surgery. I love my drinks more after robotic surgery. And on the lighter notes, probably I perform better on bed after robotic surgery. Thank you very much.
Okay. Thank you very much. That was a great presentation on the CMR system by Dr. Srivastava. So there will be some questions at the end. Are you okay to stay on, Dr. Srivastava? Okay. So we move on to the third presentation, which is by Dr. Sudhir Raval, who is a urologist. He's a medical director and the chief of genitourinary and oncology service at the Rajiv Gandhi Cancer Institute in Delhi. He has specialist interest in robotic urology and oncosurgery. He has done robotic cystectomies with neobladder, prostatectomies, nephron sparing excision of lesion in the kidneys, and also robotic retroperitoneal lymph node dissection. He's been a pioneer in using the SSI mantra, which is the robot which has been introduced in India. So we look forward to his presentation, as I think there will be a lot of interest on seeing how the system performs in comparison with the other systems in the market. Over to you, Dr. Raval. Thank you very much for taking your time off and giving a presentation today. Thank you.
Yeah. Thank you, Dr. Majumdar. I am online, but my presentation will be shared by, I think, the coordinator. I have already sent the video, which is recorded.
I'll share the recorded. I share my
Yeah,
screen.
please.
Recording.
Please. Thank you.
Thank you.
It's not playing. Exclusive Cancer Center, which is Rajiv Gandhi Cancer Institute.
Yeah, we can. Yeah. There is no voice with the video.
There is no voice.
You want to talk through this?
I can talk.
Yeah.
Yeah. So I'll start with this slide. Why robot? We all know that ever since evidence of reduced morbidity by laparoscopic cholecystectomy was there, then minimal invasive surgery has not seen any looking back. And the impact is so high that there is no RCT comparison open cholecystectomy and laparoscopic. And this is just because only problem with the laparoscopy is the ergonomics. Can I have next? I don't know whether it will play or not. Yeah. Robot was originally introduced to reduce the difficulty in performing the complex laparoscopic surgery, because you do have advantage, as the other speaker has already told us. Next. And biggest advantage which you see is the less surgeon fatigue. Mantra is is a robot, Indian robot. And next, please. I'm talking about problem with Da Vinci, as it is there for 20 years. Problem is like it is having a Merc luxury car all over the world, not a single other competition. And that is why the cost is very high, innovations are less, and there is no focus to other specialty like cardiac cases, for which actually it came. Next.
Hello.
Yeah. SSI vision is to create a new technologically advanced system that would surpass the existing surgical robotic system, and which will be very affordable cost in for the future, and it can be used all around the world. Next. So this is new robot on the dock, and we know that we have done 2 clinical trials where we used this patient and this robot in 18 cases with Mantra 1. And now we have Mantra 2, where 8 cases have been done as a clinical trial, and 10 cases we have operated regularly, because we have got this robot in our institute. On all the cases has been very complex uro-oncological surgery or gynae-oncology surgery. Like first case was nephrectomy for a patient who had even sarcoma, and he received chemotherapy already. Then we have done radical prostatectomy, radical cystoprostatectomy, pelvic lymph node dissection, radical hysterectomy, and our GI surgeon also used Mantra 1 in it, cholecystectomy for cholecystectomy in one patient. This is the Mantra 1. Next, this is surgeon console. That was robotic arms, separate robotic arms, as you see in other 2 robots. This is the endovision for Mantra 1. This is Mantra 2. This is the open surgical console, and they have the side console also, where you can integrate the all CT, MRI, everything. These are the hand controls, which you can see they're totally different as it is Mantra 1. And it uses Olympus camera 3D flexible. Next. These are hand control, which are is a close-up view you can see, and they are thumb grip. They are like palmer grip rather than thumb grip. Palmer grip. This is the robot. They are palmer grip, not like CMR has. There's a pistol grip. They are palmer grip, and they have a hand clutch in the hand control, and they have foot clutch also. And they're very easy to use, only that you just have to get used to them if you are doing Da Vinci a lot, which we do. We have 2 Da Vinci, one is X and XI both. And I have already finished 4,000 surgery using Da Vinci robot in my specialty. So my reflexes on this robot, they are taking some time to be, like using this robot. But then we have done all these big surgery using this robot. Next. This is the arm, patient's cart arm, a side cart, and they are like 4 or 5 carts you can use. and they have toggle on both sides. Right now we have used forearm. We have not used fifth arm yet. They are evolving into that situation also, and they are quite patients. There's when you dock these arms, there is no cluttering or any problem comes, and there's a absolutely modular arm which can be used in these patients. This is what I was talking vision card. This is a 3D vision for the assistant also, not only for the surgeon. This is for the assistant also, and they have recording system which they have already sold us long back, in which we are using with our Omni 3D HDTM, which has got the recording system. This is we have another one in our theater where we are using with X system of Da Vinci. Then this is the Olympus flexible 3D 1080 pixel HD camera. This is one of the best laparoscopic camera in the world, and it is used. We do not use 30 up and 30 down because it is a flexible. So we ask our assistant to just to tilt the give us a tilt, and we can see the if we need 30 or 30 up, 30 down or 30 up. These are some pre-operative innovation they are doing. These are the instruments. They have got 30 instruments like Da Vinci. Go next. Instrument range is like Da Vinci. You have all sides of instrument. These are pre-operative applications. This is the one which, please hold on that. Go next. This pre-operative application, I'll not talk to you in detail. These are the slide. Let's just stay on this. You have Maryland, you have fenestrated bipolar, you have hook, you have hot shear, then you have grasper, all type of instrument. They have what the Da Vinci Intuitive is having. Next.
I'm sorry, Dr. Sudhir. I'm trying to match with your speed the video.
Okay, I know. Thank you. Sorry. I know there's a problem. I should have sent you the slide separately rather than video. So those were the cardiac applications. These are all cardiac applications. They are used for cardiac surgery. But the one thing which I am excited, go next, is about, this is the cardiac. I'll not talk to you in detail. Next. This is multi-fire clip applicator, which probably will be again a very good instrument for general surgeon and urologist, because you can use this multi-fire clip applicator in your fifth arm if you want, and you can just dissect from two arm, apply a clip on the vessel and cut it off. This is that SS Maya. They are developing virtual operation theater planning. They have used my theater from Rajiv Gandhi Cancer Institute to where the patient cart will be there, where the robot arm will come. So this is they are evolving in this. It's not right now really used in our institute. Next. This is the first, animal trial they did, and then the cadaver trial was done. The person who you can see is Dr. Sudhir Srivastav. He is the cardiac surgeon who actually is behind this robot. This is the first clinical trial done at the Rajiv Gandhi Cancer Hospital. He is Dr. Sudhir Srivastav, who has made this robot. He is cardiac surgeon, and this was the first clinical trial done at Rajiv Gandhi. We did 18 complex surgical procedures in Rajiv Gandhi. That was before second wave. It was between first and second wave. It was in 21, January 21, December 22, January 21. We did those 18 surgical procedure. I'll not say 18 surgery. We calculated surgery into surgical procedure. Then in April 22, we did 8 complex abdominal procedure using Mantra 2. And after that, we got this robot in our institute, and we did radical prostatectomy also on Mantra 2. On Mantra 1, we did not do radical prostatectomy because this is one of the surgery which is actually mostly demanded in uro-oncology field. Next. These are the timeline for Mantra. and this is the cost comparison where Mantra actually scores. Please go to the cost yeah, no, next.
I think you're on mute, Dr. Robert. We can't still hear you.
Yeah, sorry. Can you hear me?
Yes.
Yeah, sorry, I got locked out. So this is the cost comparison which I was talking in comparison to DaVinci X and Xi. We have two robots in our country. We do not have the another system of DaVinci which is single port. So X and Xi are the robot which are available. And if you see system cost for Mantra is 4.5 crore. This includes GST also. While DaVinci X is 7 crore and while DaVinci Xi is 12 crore. And when you add the custom duty and GST on X and Xi, it comes around 15 crore for Xi and 9 crore, 10 lakh for the X. While for Mantra, it is only just a 44.5 crore. Next. So there's a huge advantage of cost of system. And then there's a running cost also, which is less in Mantra. Yeah, this is the running cost. If you can see that SSI Mantra, 40,000 if you use 4 instruments. They are charging for one instrument around 80,000, which can be used for 10, at least 10 users. They have not specified the multiple more than 10 users because they are evolving in this technique, but they are giving guarantee for 10 users. So 8,000 per use you get per instrument you have to use. So around 40,000 will come the roughly cost for a patient in comparison to the DaVinci X and Xi, which can go from 1 lakh to 1.5 lakh, depending on the how many instruments you have used. Next. Then the CMC is also here. You can see the CMC also is 1 crore per year for DaVinci X and Xi, while for Mantra, for 3 years, it is no CMC. And after that, it is 35 lakh. This is how it increases. So you save a huge cost when Indian robot is there in the market, which actually is going to happen in next few months also, because we are giving some feedback to them. They are rectifying and before installing it to Raipur and Bombay at other places, because they have got 5 purchase order in the hand and 7 more are coming. And they have done live demos for the and test drive for more than 60 surgeons, placing first robot in Rajiv Gandhi right now. And the 2 clinical trials which we have done around 36 cases so far. They have IP portfolio also, which have been granted to them. R&D Mantra 2.0 is complete. Next. I think next will be video. If that plays, that's fine. Try to play this video. Yeah, it's probably playing. This is the nephrouretrectomy which I did on a patient, and cystectomy also with using Mantra 2. He had a non-functioning right kidney. So we docked the patient in lateral position and we did the dissection with hot shear and using Maryland. You can see this, the duodenum. And this is the gonadal vessel, which is clipped and cut. And then the liver is being retracted and we are going towards the renal hilum. There's the right renal artery. And then we go for the right renal vein. Doing nephrectomy is easy with anything, like you have laparoscopy also, or with the robot also. But for the cystectomy, robot has a huge advantage as for radical prostatectomy also. So that we are going for ureter, and there's the ureter you can see, and then we are clipping the gonadal again. And then we change the position of the patient. He's in supine Trendelenburg, and we redock the robot and go for the bladder. For the cystectomy, you can see the obliterated umbilical artery, which is being clipped and cut. And then we make a space between rectum and the bladder, and then go for the lateral pedicles. We are using now these surgery regularly with this machine. We use 1 case per day on a mantra, and other cases were like I have almost 4 or 5 cases per day in robotic. Other 3 or 4 cases we do on Da Vinci. So you can stop this, and I'm happy to take any question.
Okay.
Thank you.
Thank you very much. That was a fantastic presentation, Dr. Raval. Thank you very much. I think you had a robotic human being there sort of running your slides, which was very good, and he did it very well, actually. Thank you very much. Was that Dr. Jain, I think? And thank you for that. Thank you for doing
Thank you. My apologies for all the mess up I did with the speed. Sorry.
No. I think it went very well because you showed how you can move the slides, and he just talked through the slides. No, thank you very much for that. So now I invite Dr. Arun Prasad to join me for the discussion. And I would like to thank Gapio and also the ARIS for this fantastic presentation so far, and it has worked very well. So Dr. Arun Prasad, do you want to start off with some questions to the 3 speakers, please? Thank you.
Right. So I think my first question would be to Raj, that he has used both Da Vinci as well as the Hugo system. Which one of the 2 do you think has a better future?
Okay. In my opinion, both has better future. But in abdominal surgeries, I say Hugo Ross will have a better future. And maybe urology, gynecological surgeries, maybe Da Vinci will continue to have its stay. But I strongly believe multi-quadrant surgeries, Hugo Ross is going to take over.
Okay. So actually that was going to be my next question as to which, if you have both the robots with you, which one will you use for which procedure in GI surgery?
Okay, if I'm doing upper GI surgeries, I will definitely continue with Da Vinci. And if at all it's going to be bowel surgeries other than upper GI, where I might need some small bowel, large bowel to be dissected and around, and the patient has multiple issues like a hernia with bariatrics or hernia with other surgeries, where I can have a chance to go with 3 or 4 quadrants, I definitely will choose Hugo Ross because of both forward as well as reverse docking.
Okay, that's great. So next question is actually to Rajesh.
Yes, sir.
Somebody asked, what is wrong with minimal access surgery?
Sir, this is the discussion which is there from the first day of entry of robotic surgery. And this will continue. Like initially, the discussion was with open and laparoscopy, and every time open surgery used to say, see, why laparoscopy when you can do open surgery? So right now, I admit that there is not much benefit to the patient, but the coming days is going to be robotic surgery days. That is 100% sure. Yes.
Right. So Dr. Raval, my last question is to you, which is when we had the Intuitive and the Da Vinci, we thought that this is going to be complementary to laparoscopy and it would not replace laparoscopy. Do you think SSI has the scope that it would actually replace laparoscopy because it's going to be economical and it would match the laparoscopic cost and give you all the benefits of a robot?
Sir, you're muted.
Yeah. Can you hear me now?
Yes.
Yes.
Yes,
Yeah.
yes. please.
So, we've had this discussion a lot when we go for robotic forum, especially in urology. And I am of the opinion, because of the robotic technology becoming cheap, it will go more into laparoscopic field. And actually somebody made a comment, will laparoscopy will finish? So I said probably in urology, yes. And the reason is why I say so. If you see the history in urology, there used to be open prostatectomy and that TURP. And the TURP actually was there, and there were some cases suitable for open prostatectomy. But now we have a laser prostatectomy, and the TURP is finished. And and then came the this thing, stone surgery. We have your this thing, lithotripsy. Then we have RIRS, URS, PCNL, and so many lasers. So nowadays, nobody does the open pylolithotomy or nephrolithotomy. Everything has gone to endoscopy, and that's what I finished. At least in urology, it is going to happen. And maybe in other, especially it may take some more time. Why should I be struggling with a laparoscopy for a nephrectomy if I have a cheaper thing and which is easy for me? So here, other than nephrectomy, everywhere robot has huge advantage. You say cystectomy, prostatectomy, inguinal block dissection by robot, or post chemo RPLND, where So I feel in urology definitely, and other branches also this will happen.
Great. I think that was a very bold statement you made, Dr. Rawal. And I think the webinar has really opened this eyes. And we've had people from various parts of the world. In fact, all our presenters and moderators are all in different places. And this kind of webinar is what brings people together to share ideas and share experience. So I think this has been an excellent start. This has been the first of its kind webinar where we have discussed the first-hand experience of the newer models. And I would really thank all the presenters from the core of my heart to have shared their initial experience. This is going to take it a long way, the robotic technology in future. So Dr. Selvasekar, if you could take over and give some final comments from my side, I'm
Okay.
done.
Thank you very much. Thanks, Arun. There is a couple of questions. If you have a couple more minutes, we can just go through that. This is from Dr. Sanjeev Haribakshi on how do you find the instrument articulation of Mantra system versus the Da Vinci system? Presumably that is specifically to Dr. Rawal, because he seems to be there.
Yeah. So instrument articulation is as it is in the Da Vinci. They have endorist, and they're actually in the board is the Dan something doctor who actually invented endorist in Da Vinci Intuitive when Intuitive came. So the wrist, the endorist, and everything is same as like Da Vinci. So instrument articulation is not a problem. There are some teething problem which they have sorted out, which actually we gave feedback. They have got beautifully working bipolar, fenestrated bipolar, Maryland, and there is another thing, progress and all. Needle holder are very good. So there is no problem with the instrument articulation in suturing or cutting or anything. Only thing, there is a hot shear that they took some time. It was sometime it was doing more chairing, or sometime it was not cutting, which they have sorted out. So it's going to, those instruments are at parallel with the Da Vinci system.
Okay. Okay, thanks very much. And there's another question from Dr. Haribakshi about the challenges or the limitations of each of the systems. So let me go to Dr. Palniappan. Would you just say what in your experience has been the challenge with the Hugo system, please? Okay.
So having done quite a few Da Vinci surgeries for last 10, 12 years, I didn't find much of a challenge in Hugo Ross when it comes to robotic per se. But when you compare Da Vinci with Hugo Ross, so the the ultimate space in the operation room is so cumbersome. So I had a lot of difficulty in trying to move my trolleys and other instruments in and out of the circle of spaghetti is what I call in terms of Higueras with 4 arms on 4 different sides. Then I had a problem with insufflator not being in the system, a separate trolley for insufflator, and little bit of more dead space equipment inside. The third is the flimsiness of the instruments. I mean of the whole process. Plenty of small adjustments are needed. 10, 15, angulations and tilts and heights and stuff like that, which has to be done at different levels. Not like in a Da Vinci where we just pull one arm and move around whichever we wanted to. So you had just a height separately and tilt separately, plane separately. So you had to keep doing 10, 15 steps of cross checks every single time. So those kind of things are all, I think it's too much of an activity, which maybe with the time to come, they will address it. Another big issue, what I saw, is a paucity of instruments as of now. Even though they are telling that they are going to have staplers and vessel sealers, as of now, except for graspers and dissectors and needle holder, everything else has to be assist port. So as of now, it's what I call a robo-supported surgery and not just a robo-assisted surgery. So you need to be a very good lab surgeon as of now to tackle Hugoras until the equipments are coming in.
Okay, thank you very much. Thanks. Next to Dr. Srivastava, what do you see are the limitations or the challenges with the CMR system?
So the first thing is, I said that I have completed 12 cases, but in one case I have to convert. That was supraumbilical hernia, and we tried inferior dog and all the 3 ports in pelvis like we do in supraumbilical. But the problem probably was my port placement, then robot. But yes, they have a problem when you place the port in pelvis. They have a little bit. I was struggling with the movement of my hands. Number one. Number two, their length of play is at present 5 centimeters. Probably they are coming up with 3 centimeters. So this is a great challenge for doing the surgeries because I am more inclined towards hernia surgery. So I am looking for ETEP reeve-stop and ETEP task. So probably this reduced length of 3 centimeter will help me. Third thing is electrocautery system. So they don't have vessel sealer system, but I can definitely say the moment they will come up with vessel sealer ultrasonic device, total laparoscopic hysterectomy, that is TLH, will be fun with this robot, CMR robot, because docking of CMR robot is the minimum challenge. It's very simple and it is as good as a laparoscopic surgery. You have to take the instruments are there, and as Dr. Raj was telling, you need not to do so many manipulations for docking it. So it is right now it is 20-minute job at my center. But yes, these are the few challenges. Vessel sealing system is very important. The moment it will come, it will pick up in a huge basis for general surgeons and general gynec surgeons.
Okay, thank you. Thanks very much. Over to you, Dr. Rawal. What do you see with your experience are the limitations of the SSI mantra at the moment? I think you're on mute.
Yeah. Okay, now. What I see is, Da Vinci comparing with the mantra is, Da Vinci is a 20-year-old technology and they have improved upon it. There were reports in the beginning, malfunctioning of robot, and then they were, they had to convert the surgery, and it has happened in many places all over the world. So same thing mantra is facing now and is facing in one center only. It's not that it has gone to other center. Once it goes to other center, then we will come to know many things, what is going to happen and what the improvement it requires. As on today, when I use this robot, I am not as comfortable as I am in Da Vinci because I have done already so many surgery. But with time, I think my reflexes will improve. And with feedback from us, they will improve what movement we want. because in pelvis, there are a lot of movement which we require. Sometimes they are so complex that they cannot be, replicated even by laparoscopy or any other thing. If you ask me, I'll do 3 surgeries still with Da Vinci in my hospital. That is post-chemo RPLND, robotic video endoscopic inguinal lymphadenectomy, and third is ridges-sparing radical prostatectomy, which I am not very comfortable doing with mantra as on today. But in future, once their refinement occurs and my reflexes improves, I will be able to do all these surgeries. So I think this technology will evolve in next few months to 1 year, and the things will be probably at par with Da Vinci.
Thank you very much. I think one thing which is very clear is the speakers of all are very experienced laparoscopic and robotic surgeons. So you've taken this new tool and then showed the benefits. So there's one question from Dr. Saeed Farkan on the learning curve. Can we have some thoughts on that, and then we'll finish with that. So what are your thoughts on learning curve and training, Raj Palniappan, with the Hugo system?
Yeah, see, Da Vinci have done extensive research with the last 10-15 years on the training. So they say 20 surgeries is what it takes for a surgeon to be a master of a technique. And some surgeon does 1 surgery a week in the next coming 90 days after he finishes his training, he will be more a sustainable robotic surgeon. And 20 hours of simulation, minimum of 8 hours of simulation, and rest 10-12 hours of hands-on and clinical observership is good enough to start your training, your robotic work. So I think the same will go well with Hugo Ross. The only difference is if you are a laparoscopic surgeon or a Da Vinci robotic surgeon, I will say I took only 1 case to move towards a good Hugo Ross. So maybe worst come worst, you can have 3 to 5 cases for a trained robotic surgeon, or the same 20 case like a Da Vinci for a lap surgeon. Maybe a little longer for a general abdominal surgeries for an open surgeon, but for gynae and urology, it can hold us the same 20, because gynae laparoscopy is okay, but then urological laparoscopy is much more complex and difficult to do. So that way, an open surgeon is good enough. But I believe an abdominal surgeon has to be a lap surgeon to be a good robotic surgeon.
Okay, thank you very much. Dr. Srivastava, what do you think are the training opportunities, or how should one train with the CMR system?
So, as I said, if somebody is expert laparoscopic surgeon, it is hardly a couple of cases which are needed to become an expert laparoscopic robotic surgeon. But yes, if somebody is starting, like somebody has asked, the learning curve for a beginners, definitely there is a learning curve for beginners. The best part in CMR robot is they have inbuilt training program, and you can very well, without any cost, you can do virtual training, and definitely that helps. But yes, learning curve is there. No surgical field is without learning curve. There is learning curve, and to me, I admit 20 cases are far sufficient to become an expert robotic surgeon.
Okay, thank you very much. Finally, Dr. Rawal on the SSI system. What are your thoughts on the learning curve? Do they have similar sort of a training module, or what is its current recommendation?
No, they do have training module. They do not have simulation yet, and they take the surgeons to workshop. They actually ask them to operate on goat heart. They can do suturing, they can do cutting, they can do knotting and all everything. For them, like as everybody said, the trained robotic surgeon like me, I took only right from the beginning I started, but I was comfortable after doing 7 or 8 cases. But then who has not done robotic, they may take around 20 cases, and especially in depending on their field. But those who are trained laparoscopic surgeon, they will take definitely less time on learning this machine.
Okay, thank you very much. I think this has been a fantastic series of presentation, I should say. There are lots of questions, like we can talk about governance, we can talk about specialty specific need for these robots, and also various other issues, the need for registry, the role of organizations, going forward. But I think time is running out. We have over 90 minutes now, and we still seem to have managed to keep the 30 to 35 delegates online. So we probably can conclude. And I think Dr. Arun Prasad is still there. Do you want to say anything, Arun, or I can just finish it off?
No, I can just say that
Thank you.
it's been a real good webinar, and Selva, please carry on and conclude.
Thank you very much. First of all, thanks very much for Gapio and for Aris to do this innovative webinar, because it has been bringing together what is available in India at the moment and also discuss what the opportunities and challenges. One of the things we can probably look at going forward is look at the training opportunities and also the role of the association like the Aris and the need for registry, as I mentioned, because at the end of the day, it is, yes, there is benefit for the surgeon, benefit for the hospital, but the true benefit has to be for the patient. So how do we triangulate that going forward? And I would like to thank Dr. Anupam Sibal and also Dr. Sushil Jain, who has played a big role in making sure that the SSI Mantra presentation went well. Thanks all the delegates and those who have contributed to the discussion by contributing to the chat. Thank you very much, and happy Independence Day tomorrow.
Thank you. Thank you, everyone. Thank you, Dr. Arun, for giving me this opportunity. I did not know about this association at all. Being urologist, I am totally I'm really sorry for that. But then it's a great interacting with you all. Thank you, sir. Thanks a lot.
Thank you.
Thank you very much, sir.
Thank you.
Good night.
Thank
Good
you so
night.
much, Paul. Thank you.